just like to let you all know that. Not that you're gonna be recorded. But anyway, so if you'd like to watch this webinar again or share it with any family members, friends, or even your doctors, we'll house it on our website and we'll send you the link in the next couple of days. So welcome to our series called Prepare for Victory Virtual Medical Symposium Series. We created this program because we want to give you, no matter where you are in the world, the opportunity to hear the best information on Marfan syndrome and related conditions from our professional advisory board and other leading medical experts on these conditions. And we're so grateful to the Chu and Chan Foundation for their support of this and making these webinars possible. So our speakers tonight are Dr. Paul Sponseller, a member of our professional advisory board, who is the chief of pediatric orthopedics at Johns Hopkins, and Dr. Adam Bitterman, an orthopedic surgeon who is a foot and ankle specialist at Northwell Health in New York. Dr. Bitterman brings medical expertise as well as a unique perspective because he also has Marfan syndrome. As you know, tonight's presentation is on keeping your spine, limbs, and feet healthy in Marfan and related conditions. If you have questions during the presentation, please type them in the question and answer box, which you can see on your screen. We're going to leave time at the end to answer the questions. So now I'm going to pass the remote control over to Dr. Sponseller, and we're going to see how this works.
Okay.
So Dr. Sponseller, you take a minute and grab that screen, that remote control, and okay.
Is that?
We got it, and now just.
Can you see the full screen?
We just see we see the sidebar. So just slideshow, and then from the beginning, and then we'll be good. On the top there, slideshow.
Slideshow.
A little bit higher, right over there to the left, slideshow, and then from the beginning.
I don't see slideshow.
Right there, right up. Go up a little bit more.
Pause share, new share.
No, it's not on that panel. It's on your screen, slideshow. On the orange.
I don't see it. Okay. Yeah, it was hidden by the.
There you go. Yeah, and then from the beginning, and you're good.
From the beginning, what does that mean?
Oh, well, we're not seeing the beginning of your slides. So anyway, you want to just scroll up, and then you can start from the beginning of your slides because we're. There we go. You can do that.
So.
That's fine.
Yeah. The topic of my talk is to talk about healthy limbs, feet, and spine, and co-doing this with Adam. The things I'd like to focus on would be spine issues, including dural ectasia, and then hips. And then Adam will take it from there and talk about feet and other quality of life issues. Just so you are aware, the main health concerns in Marfan syndrome are followed by the heart and the eyes. The back and generalized fatigue, especially feet and hip, are some of the main concerns that bother people in Marfan syndrome. And if you focus on the skeleton, hip pain, neck pain, and knee pain are right up there among some of the top problems that people experience with Marfan. So on the spine, I'd like to cover scoliosis, kyphosis, and slippage or spondylolisthesis. I think that these are all things you've probably heard of, but I'll define what each one of them means as we go through this. Scoliosis refers to a curvature of the spine, and it affects about 2 out of 3 people with Marfan syndrome to various degrees. It's not always severe scoliosis, but it can be in some cases severe. It doesn't always worsen, but about 10% of people will need either a brace or surgery. And if you compare people with Marfan to others with scoliosis, they tend to have their curves increase faster, and they tend to have more back pain. As you can see, this patient went from a mild scoliosis to severe scoliosis in just 3 years. A common question is whether bracing will help scoliosis. And in a certain degree it will. It won't straighten the curve, but it may hold it. When we studied bracing in Marfan syndrome, we found about 1 out of 5 had a real success. 80% still got somewhat worse, although sometimes it may be of some value. The types of braces we're talking about include either the knife brace in the dark blue here, or the custom standing brace called the RCO brace, which is depicted on the left, the more colorful brace. The problem, however, is that the bones are very prominent and sometimes uncomfortable inside a brace because of the severe twist and the rib shape, and also the lack of padding over the bone. So I like to start bracing at an earlier point, usually when curves are as small as 15 to 20 degrees in young growing children, and avoid it in low yield situations. Kids will come in with a very big curve that's already kind of too big to be braced, and they may be very uncomfortable, or a child who just cannot wear the brace because their life is too complex, they have other medical issues, or they're just not able to bring themselves to do it. A special case is the infantile Marfan patient, somebody who has scoliosis that's severe even in the first 2 or 3 years of life. These are kids who often will need surgery before they reach a decade. And the problem is that fusion can arrest the growth of the trunk and stunt their growth. So the solution is to have a rod that grows with the patient, like an internal brace. And you can see an example of that here, the patient with a severe curve beforehand, and then with some small incisions, the trunk is controlled and the spine will grow with them. In recent years, these have been perfected and used to require multiple surgeries to go in and slightly spread these rods apart. And we found good results in these patients with Marfan syndrome. But now we have another tool called magnetically controlled growing rods, acronym being MAGIC. And if a child doesn't need an MRI, you can actually do the lengthening awake in the clinic with this little magnetic device that turns the screw in the rod, and it makes it get longer, minimally invasively, non-invasively actually, and helps them to grow as long as they still have growth remaining. This is a real revolutionary aspect in young patients. It's not necessary for older kids, however. As they reach teenage, there's no need to further grow, but it's just a matter of controlling the curve. And this is commonly done in typically occurring teenagers called idiopathic scoliosis. But when you compare that to Marfan patients, as we did, matching them and comparing them, we found out that the Marfan patients tended to have more difficulty with rod complications, need for reoperation, spinal fluid leakage, or worsening of curves outside the main curve. So you have to be careful to control the whole spine. We also found that some people with Marfan syndrome will have slippage of the spine, called spondylolisthesis. This is common in the general population, but a person with Marfan syndrome who has the slippage is more likely to keep getting worse and to go forward. So these can be treated usually with the posterior fusion only, going and just kind of controlling those two levels that are slipping forward. Throughout the spine in Marfan syndrome, there are many bony changes that characterize the condition. And these are that the structures are all very thin, like the pedicles. The linkage between the front and the back of the spine is called the pedicle. This is very thin in Marfan patients. And the back of the spine, called the lamina, is very thin. And the bones themselves are very scalloped, as you can see in this bottom left picture. The dura is big, and the dura actually scallops or erodes into the bone in some cases. You can see it on the MRI, shown here, and you can see it on the CT scan, shown here. Duralictasia is probably a term you've heard because it can cause symptoms and also cause concern in many people with Marfan syndrome. Some would say that almost all Marfan patients have it to some degree, as do Loeys-Dietz patients. And this just basically consists of a scalloping or an anterior sac of dura. And just to be clear what dura is a tube that's supposed to be tough tissue, almost like burlap, that covers your spine and protects your spinal cord. It contains the clear fluid called spinal fluid. In Marfan syndrome, this dura is more porous, and we studied the electron microscopically, showing that the dura is not tough anymore, but it's actually thin and has holes and can be very stretchy. And so the spinal fluid pulses and gravity makes the dura stretch out, and it dilates, it fills up more space, causes pressure on the spine, and even can cause some pressure on the nerve roots. Does dural ectasia cause pain? In most cases it does, although there are some patients who have dural ectasia and don't have any pain. We don't know why the difference exists, but on the whole it's likely to contribute to various types of pain, from pressure on bone, pressure on soft tissues, folding of nerves, and possibly other signaling mechanisms. The problem, however, is we don't have a really effective treatment for it like we do for the aorta and the cardiovascular issues of Marfan syndrome. The symptoms that people get with dural ectasia include pain in the very lowest part of the back or even the tailbone. They can get headaches from fluid shifts up and down the spine. They can get leg pain, and they can even get pain in the perineum or the pelvic or the rectal region, again, because the dura is most dilated down near the very bottom of the spine where those nerves live. Does dural ectasia get worse over time? We tried to study this with an 11-year follow-up of a dozen patients who we had scans from in 2002, and we followed them up 10 years, 11 years later, and found that they had actually not gotten any worse over time. So here's an example of one patient who had this finding in 1998, and then 2009. It was really just about the same. Here's another person, a man, who had dural ectasia. You can see that it has kind of this shape in 1998, and in 2009 again, very similar, and the net volume is not actually increased. So it seems to be something that comes on during adolescence and growth, and probably grows then, but then in adulthood it does not tend to keep getting worse and worse and worse and eroding. It tends to be more static. So we found that if you measure the volumes of the dura, it actually does not get any worse time at L4, L5, S1, or S2 levels. In some cases, dural ectasia is kind of refractory to pain. So after various physical modalities, strengthening, braces or corsets, there is kind of a final option for people called spinal cord stimulation, which helps chronic axial pain. It works on what's called the gate theory by blocking these painful impulses with other types of signals using an array of electrodes connected to an power source. So this is something that has been useful in patients with Marfan syndrome and dural ectasia and chronic back pain that haven't been able to get help by any other method. I'd like to briefly touch about some of the hip issues in Marfan syndrome as well, going from childhood to adulthood. In the neonate, you can have hip dislocation just like you can in a typical child. In Marfan syndrome, however, it's a little bit more common, about 2% compared to 0.1% in the general population. The usual braces called Pavlik harnesses are not successful because the knees and hips are just too loose. But a cast, putting a child in a cast with the hip in place actually produces a surprisingly good result. As you can see in this person, shown at 2 months, and here at 30 years of life, the hip is in the socket. It did develop normally, and it's no longer dislocated, although it still has some differences from normal. The bigger thing with Marfan hips is that they deepen their hip socket called protrusio. And this is where the pressure of the bone against the body weight can kind of migrate the bone into the pelvis a little bit, because the bone is actually more plastic under these large amounts of load with growth and possibly chemical activation of osteoclasts. And this is one of the things that leads to hip degeneration and early hip arthritis in Marfan syndrome. We found that about 5% of Marfan persons has hip pain, and a few people need hip replacement in the early ages of 40, 50, when typically developing people would not need it. But hip replacement has very good results. It does a great job relieving the pain. Apart from a slightly higher early redislocation rate, it actually does a great job relieving pain and can be confidently recommended if you find yourself in a stage of hip degeneration. So I think those are the things I'd like to cover, and then I'd like to stimulate people to think about some of the unanswered questions we have in Marfan syndrome. We don't know why they have the bone density issues they have, the osteoporosis or osteopenia. We don't know why they get these changes with thinning of the pedicles and thinning of the lamina. It probably has to do with TGF-beta signaling. And we don't know why they get so much unexplained skeletal pain, fatigue, and in some cases, premature disability. These are some of the things we'd like to solve in the next decade or two with the resources of basic scientists and the Marfan community. I think that we hope to be able to give better quality to now increased years that people are living and try to put people on a better footage. So I think that from my end, I'd like to wish everybody a very healthy 2019 and pass it on to Adam so we can learn from him about the rest of the skeleton.
Okay, so I'm taking the remote back, and let me just share this. Let me just share that again, and now I will give this to.
I think it should be up.
Are you good?
Yeah, I have my my slides up.
Okay, great. Okay, all set then. And let me just say quickly that we're going to be archiving this this webinar. So I know somebody asked that. So go ahead, Adam. Thank you.
So thank you, Eileen. Paul, thank you for the transition. Good evening, everyone. Thank you for joining us. My goal is to focus mainly on the lower extremity and also on some important details surrounding quality of life, which affects both men and women in different phases of life and also in different aspects of life. So I'll do my best to cover them as quickly and as efficiently as possible. So again, the reason that this is so important, not only from the foot and ankle standpoint, but for the quality of life standpoint, is our patients with Marfan syndrome are living longer than ever. With the advantages in the basic science community and the advances, made in cardiovascular surgery, we're able to live longer. And as such, these problems that used to never be brought to fruition are now real life issues. So people are living longer and they're putting more wear and tear on their bodies and their tissues, which are normally not able to withstand the long-term activities. And as such, we need to come up with better solutions to solve pain and other aspects that affect quality of life. So that's one main reason why this is so important. So why is the foot and ankle so vital? Well, there really isn't any other area of the body that can withstand roughly 10,000 steps each day for 15 years, 20 years, 30 years, 40 years, well into people's 70s, that doesn't break down. So it's quite remarkable how well these parts of our human anatomy function. So essentially, they're high trafficked areas. There's a lot of structures traversing the bones of the lower extremity. Many things are active, many things can go wrong as a result. So we need a better understanding because patients with Marfan syndrome, the tissues are not the same. So being able to come up with solutions that fit that patient population may not be what you may read or hear about from your friends, your colleagues, etc. So having a good understanding of the pathophysiology, what goes wrong in patients with Marfan syndrome is extremely important. So the classic foot of someone with this syndrome is as seen here. The foot is flat, the arch is no longer maintained, the digits are extremely long, and they're obviously very flexible. With this, there are certain problems, mainly with function, number one, strength, number two, and also with cosmesis. So certainly patients of all ages and of all genders have various concerns surrounding their feet and ankles appearing like this, but also finding appropriate shoes. Not every shoe manufacturer has those patients in mind with Marfan syndrome. So you have to be able to find a shoe that accommodates the architectural changes as a result. So pes planus is the medical term for flattened feet, as you can see here, mainly on the right-hand side. So certain things that we recommend, or that I recommend when caring for this, is finding the right shoe. Finding the right shoe that has a widened toe box. Finding the right shoe that appropriately accommodates the different size and shape as compared to someone else who does not have Marfan syndrome. Bottom left-hand corner, you see a generic arch support. Again, this would be the first-line treatment in someone who has the classic flat foot deformity, as it's a gentle, soft sole, something that has cushion, but also has appropriate support to improve the arch. Wedges in regards to the separating the big toe from the lesser toes can help prevent bunion deformities. It may not prevent it inherently, but it may prevent them from getting worse. And then we look at custom orthotics down the line as well, as there are certain cost measures associated with them, and they can be cost prohibitive. Certain insurance companies may or may not cover them, so that's a whole issue in and of themselves. But what the main goal here is to neutralize the foot, as you can see in the lower right-hand picture, where the patient, we're looking at the individual from behind, and you see the left foot has this outward appearance where the heel is going left while the rest of the leg is straight up, versus the right foot, which has more of a parallel alignment. And that's mainly just from a gentle arch support and the heels being neutralized from the heel cup of the orthotic. So again, any condition relating to orthopedics, certainly we want to go conservative first, so orthotics would be an appropriate modality. As this begins to fail, or this does not necessarily work, that's when we would then begin to look into alternative measures. Now, unfortunately, this part of the human body in the Marfan syndrome community has not been up to speed to the level of spine or other areas, particularly cardiovascular or even ophthalmology. But nonetheless, there are improvements being made, and with significant deformity, certainly a fusion is a viable option. When the soft tissues are no longer restraining the deformity, unfortunately, we then have to resort to definitive bone fusion modalities to appropriately align the foot. Now, the question then becomes, if you do in fact do a soft tissue procedure, you're ultimately looking at repairing pathologic Marfan syndrome tissue to Marfan syndrome tissue, and we know that that's usually not successful. So augmentation can be performed, and what that means is essentially using other tissues or other modalities such as cadaveric tissue to supplement the repairs that you're trying to perform. In this picture, this is a subtalar fusion, which is a very powerful operation, not for everybody depending on age and functional status, but nonetheless can be used when there's significant hindfoot valgus or hindfoot turnout, similar to those seen before in the earlier picture. With regards to the ankle, when the ankle gives out after sufficient injuries or sprains, which are tears in the ligament, we need to find better measures because, again, repairing tissue paper to tissue paper is not successful. And that's where more reinforcement modalities can be performed, utilizing these two commercially available techniques. The upper right photo or the upper right drawing is one that is a proprietary product used on the market to supplement a tissue repair. The lower right-hand corner is using cadaveric tendon tissue to replace your native lateral ankle ligaments. And this would be used when physical therapy fails, when orthotics are no longer used or no longer useful, when bracing has reached its outer limits. And again, everybody's different, so certainly it's important to understand the patient and the goals prior to moving forward with something like this. I'm going to transition here now to quality of life. And listed on the left are many, or a few of the many concerns related to Marfan syndrome, mainly endurance. Fatigue is a huge one, strength, and with strength, comes performance in athletics or athletic restrictions and other sporting events. Pain, as Dr. Sponseller mentioned before, gastrointestinal concerns, oral health and well-being is certainly a major avenue for research interest. Cosmetic concerns, frequently not spoken unless you're involved in the community, but a lot of times this is misunderstood. And then with that comes the psychiatric component of that, and also pregnancy. For the women listening, I don't necessarily go into this in much detail, but certainly there are many articles that we'd be happy to send you that do highlight this. So pain. Unfortunately, as good as we are, like Dr. Sponseller said, we don't have a great understanding on exactly the true cause of pain, because there are many symptoms that can present as pain, and unfortunately, no two patients presenting with pain have a similar presentation. Related to the musculoskeletal or the orthopedic standpoint, scoliosis or the curvature, as mentioned, to the spine is a major possibility and a major cause. TGF-beta and other cytokines are important chemicals that are floating around the bloodstream. They may be related to the causing pain. Dural ectasia, as mentioned, and then the degenerative arthritis or the bone-on-bone contact that results from these deformities, particularly in the lower extremity. Again, when you're walking 10,000 steps, when you're active or as active as you can be in your daily life, working or even socially, eventually all things break down and lead to wear and tear, which can cause pain. So Dr. Sponseller in 2016 with his group out of Johns Hopkins, they published an important paper on the quality of life, and they sent out surveys to 230 patients, and they found that the top concerns amongst those patients with Marfan syndrome, aside from the cardiac, which is the main life or death focus, is the quality of life. And that's the back pain, that's the fatigue, and those were your top three right there. With regards to the clinical manifestations or how it presents amongst patients with this syndrome, everybody is different. So it kind of makes sense that you can't really compare yourself with Marfan syndrome to your friend who has Marfan syndrome, because the phenotypes or the way that we perceive this syndrome are totally different. So no two types are the same. And unfortunately, here in the United States, as compared to our international friends, the quality of life here is much less. So people are reporting that their quality of life is affected to much greater detail than those outside of the United States. And those that are most affected from this pain include those in the 25 to 45 years of age range. Fatigue obviously is extremely important regardless of age, because it can affect multiple aspects of your life. In particular, the social interactions are vital, because that helps with our well-being, and that can be in a social aspect, that can be in an athletic aspect, and overall, for us to grow and prosper, we need to have interactions. Inability to function in workplace, obviously, there are many economic consequences associated with that. With fatigue, you can have feelings of depression and anxiety that can be increased or compounded. Inability to cope with daily activities, things that we used to take for granted, now we can't deal with them anymore. We have difficulty dealing with them. And then as a result, we have to modify what we do. And that's where things can really get bad, because you're taking bad to worse as you no longer can participate in the things that you used to help make yourselves happy. It's now much more difficult. With regards to athletic participation, this is a huge one, as there's been some famous athletes recently in the past 5 or so years who have come forward with their diagnosis, particularly in the NBA. Nonetheless, this is another avenue for interaction with others, in particular with children of all ages, both male and female. It's important for their mental well-being to interact with others. Now, this is something that you have to approach with caution, because when you hear about someone in the media who has Marfan syndrome, again, going back to what I mentioned before, you can't compare their case to yours. So while they may be playing a competitive sport or some type of athletic competition, it's important to understand that that may not apply to you. So no one size fits all. There's an individual approach to everyone, and certainly it's pretty intuitive, but you obviously have to consult with your individual cardiologist before making these decisions. But nonetheless, it's extremely important and plays a vital role as an orthopedic surgeon to take this into account. So it's important to monitor your heart rate, monitor your SBP or your systolic blood pressure. That's the top number. You want to avoid exertional activities, anything that involves you holding your breath, which ultimately increases the pressure in your thorax, on your heart, and the outward pump, which is connected to the aorta, which is an opportunity for the aorta to expand as the pressure expands. And that's what we're trying to avoid here. Fortunately or unfortunately, there's no general consensus. So I can't point to someone here in the audience and say, you can't participate. You may be able to participate. It's just to what level you can participate. And obviously, given the chest concerns, the pectus deformities, the lens dislocations, contact sports are generally forbidden. And as a result, you're preventing trauma to the chest, you're preventing worsening dislocation to the lenses, and you're ultimately preventing major catastrophic vision loss. So certain modifications can be made. Nothing is set in stone. And obviously, as research continues to advance and more studies come out from a cardiovascular world, we're able to modify this and enhance someone's athletic participation. So overall, everybody needs to be on the lookout, and that's across the board within the medical realm. As orthopedic surgeons, I personally have diagnosed this a couple of times on patients who did not have any clue that they were having, or that they had such a syndrome, excuse me, whether that be Marfan syndrome or Loeys-Dietz. These patients come in all different shapes and sizes. They're all different ages. And it's important not to bury our head in the sand so we can do the best that we can to prevent any catastrophic consequences. Nobody is cookie cutter, so that's why everybody presents differently, and a multidisciplinary approach across all specialties is vital for early recognition and early treatment. So think positive. There's an equivalent lifespan, and ultimately the goal will be to continue to improve one's quality of life. Thank you.
Thank you so much, Dr. Bitterman, Dr. Sponseller. We're going to go back to me now. And I want to let you guys all know that Dr. Sponseller and Dr. Bitterman we're really pushing for the fact that most of this webinar be driven by your questions. So we are going to get to those in 1 second, because that's going to be the rest of this webinar, which is like another half hour. So you guys can get your questions answered. So before we move on, though, both Dr. Sponseller and Dr. Bitterman, they addressed the fact that there was not a lot of research in orthopedics. There were things that were still unanswered questions. There were a lot of pain questions. There's quality of life questions. So this is my opportunity to put in a plug for Backpack Health, which is a way that you all can help keep track of your own health information. It's all in one place. It's an app that you can download for free. But what I think is really important here is that you can also help advance research on a lot of these questions that were mentioned today during this webinar. And you subscribe to the app, and then you can join our registry. It's the first international patient registry on Marfan and related conditions. It's right on our website on the top. So there's a link that you can click there. So now I want to move over to the questions from you all. I guess for Dr. Sponseller to start with, how successful is back surgery, insertion of rods and screws for adult Marfan patients 60 and over? Would you do it on somebody that age, and who would you do that on, and how successful is it?
That's a great question. Again, no cookie cutter answer, but it can be done if there's a real need. Spine surgery in adults is a bit more difficult to recover from than it is in teenagers, and there are more potential pitfalls. But it can be done if you're having excruciating pain that's not responding to any other way, or if the posture is continuing to deteriorate and causing you to have trouble standing up straight. So it can be done. It can also be done if there's severe kyphosis, if there is a severe slippage of the spine with nerve compression issues. And so properly chosen spine surgery can be successful, but there are many other, settings of back pain that are not easily amenable to surgery and are better treated by physical modalities. So if the surgeon feels like it's really necessary and the patient is having enough problems, spine surgery can be done at nearly any age, and certainly into the 60s and even 70s for proper circumstances.
Great, thank you. That was a great question. Dr. Sponseller, another question for you. Is there a connection between scoliosis and tremors?
Interesting. Tremors are usually mediated by brain issues with balance and coordination, and there's not a direct connection, although people who get tremors are more likely to manifest inability and weakness to control their trunk. So you can get more kyphosis, more stooping, more difficulty with falling. So in that sense, there can be a relationship, but tremors themselves do not cause scoliosis.
Okay, Dr. Bitterman, here's a question for you. I'm guessing an ortho doctor specializing in foot and ankle is the best doctor to see for orthotics. Is there anything out there for women and girls who want to wear open-toe shoes and still have good support?
So, great question. I don't personally fabricate my own orthotics. So I work with a specialist called an orthotist, or someone who creates orthotics and custom braces. I feel in my practice that they're better equipped to spend the time to measure, mold, and modify as needed. So depending on what area you're in, you may want to seek out the expertise of an orthotist, or certain podiatrists do orthotics as well. So that's for that part. And regarding the open-toed, unfortunately, I don't know of a particular brand that has that, but Birkenstocks have the thick sole, the cork. Sometimes that can be accommodative for certain deformities, and that can be utilized as well.
Great, thank you for that very thorough answer. We have a question. I don't want to go into the specifics of this person's personal situation, but she's basically asking about a procedure called HyproCure for ankle instability with her son, who is a form of Loeys-Dietz syndrome.
Yeah, I can read them also. Yeah, so what that individual is asking is a specific procedure which is called an arthroresis screw. So essentially, it's a screw that goes into a particular location in the hind foot, in the articulation between, or the joint between the talus bone and the calcaneus bone. And that can play a pretty vital role in correcting the alignment, and it can be a temporary thing, because generally speaking, you don't want to leave these in for that long. And it can, as they are asking, it can limit the malalignment in the future, but certainly serial examinations and follow-up are important. I don't know, Paul, are you doing any of those screws in your practice?
I'm not. It seems like, it seems like it depends on good bone density and good ligamentous support. So I haven't been, and most of my friends haven't been, but we're interested. If it works, then certainly we would love to go for such a minimally invasive procedure.
Yeah, so I would agree. I have not done any in this population, but certainly it's one where it's a quick in and out procedure and can have great benefit.
Great, thank you. Can you also touch upon this next question about vitamin D and fatigue, Dr. Bitterman?
Sure. So the question is about vitamin D with fatigue. When I think of vitamin D, I automatically go to bone health. I'm not providing vitamin D for patients with fatigue. I know certain B vitamins are important for fatigue, but beyond that, I would consult with your primary care for vitamin supplementation.
Okay,
I agree.
Great. All right, thank you. So I'm not sure who wants to take this. Are steroid injections and foot night brace okay with Marfan patients in conjunction with PT, physical therapy?
So I can take that, Paul, but I always exercise caution with steroid injections, period. When you inject this solution in an area near a tendon, there's always a risk of it rupturing. And Marfan syndrome tendons in general are not the strongest, in the sense that obviously the tissues are much looser and more flexible. So each pathology or each indication for an injection is different. With regards to plantar fasciitis, I have injected, and a night splint is excellent with regards to treating that, but also gel cups or extra cushioning underneath the heel.
Great, thanks. And also, Dr. Bitterman, any suggested brands for women who have long, thin Marfan feet, other than New Balance? Apparently New Balance is popular, but any other brands that you know of from your patients?
So New Balance is popular because it's very accommodating. So it's got an open toe shoe. It comes in different lengths. It comes in different widths. The other brands that are similar are Saucony and Brooks. Asics is also another good one, and they have a good sole. And again, no financial disclosures related to them. But while we're on the topic of shoes, Eileen, if I may, I know that
Sure.
Nordstrom's, they provide 2 separate sized shoes without having to buy 2 pairs, depending on the size differential. So those who have different size shoes, definitely look into Nordstrom's, because that can be beneficial.
Interesting, did not know that. Dr. Sponseller, at what age should someone have a DEXA scan? Can you tell us what that is, and then what age people should have it?
Yes, a DEXA scan is a way to measure your bone density in different parts or in all parts of your body. So if you want to know if you're having osteoporosis or osteopenia, that's a good way to really be sure. A plain x-ray doesn't tell it as well. It gives you an impression, but it doesn't answer for sure yes or no whether you have it. So a DEXA scan is a simple test. It just takes a few minutes, and it's widely available in different places. So children can have it as well as can adults, but they have to be able to be still for the duration of the test, and the people who interpret the test need to understand how to rate children, because the values you get for an adult at a given age will not be relevant to children. So you need to especially know that the person reading the study, in other words, giving the interpretation, can understand children. And that usually means going to a children's facility or a children's hospital or a children's radiology center. So if you take those precautions, you can get useful information, especially about juveniles and adolescents who have not reached the end of their growth if they're having bone issues.
Great, thank you. Dr. Sponseller, here's a question about pectus carinatum, protruding chest bone. How successful is bracing for that?
It's mildly successful. You can try to guide the growth of the front of the chest, the ribs, and the sternum by bracing it against a soft, flat surface. I think it has a mild benefit, but it's really not. It's not dramatically successful like the Nuss procedure is, for example, with excavatum. So it's worth trying. The problem, of course, is that the bone of the sternum is right underneath the skin. It doesn't take pressure that well, and it's easy to get sore from it. So it's worth exploring. And the person that typically treats that is a pediatric chest surgeon or thoracic surgeon, and it's something you can talk about with them.
Great, thank you. Here's a question about shoulder health. Is there anything that you'd recommend to preserve shoulder health? I guess Dr. Sponseller, you could start.
Yes, the shoulder joint is different than many other joints. It's really dependent more on the muscles than it is on the bone itself. The shoulder has to move so far in so many different directions that it's like a great big golf club on a very small golf tee. So it has to be controlled by muscles and ligaments. And as you can imagine, there can be challenges in Marfan patients especially with the muscles as they age. And the usual issue with that is just rotator cuff tendonitis, and biceps tendonitis, and sometimes some internal ligament issues. Many times non-steroidals and physical therapy can be helpful. In some cases, surgery with an arthroscope can help. And in less common cases, various open surgery may be necessary for that. But physical therapy and strengthening and stretching are the mainstays of treatment for that.
Great. That actually kind of leads into the next question because you're talking about strengthening. And so here's a question, maybe Dr. Bitterman, maybe you want to talk about this, about strength training if you're going to be wanting to build up a little bit, but it's causing pain, so or back pain. What do you recommend in terms of strength training? It's sort of quality of life, sort of pain, sort of orthopedic.
Yeah, I mean, this is a difficult area. So strength training in general in patients with connective tissue disorder is a hard one because it depends on how much you can do. Most strength training involves, or the strength training that I'm thinking of involves lifting weights, and heavy weights are what you want to avoid because you don't want to have that exertional pressure leading to an increased blood pressure, which ultimately will cause your aorta to expand. Lower weight and increased reps may have a benefit, but again, I would encourage appropriate consultation with your cardiologist. So, yeah.
Okay. We actually we redid our physical activity guidelines on our website at marfan.org. They're not new guidelines, but the doctors on our professional advisory board took extra steps to explain why they have the recommendations, like what they worry about, and sometimes it's cardiac issues, sometimes it's eye issues, sometimes it's strain on the joints. So take a look at that on our website at marfan.org. It's the physical activity guidelines. Do all people with Marfan syndrome have issues with deformed feet, Dr. Bitterman?
Yeah, yes and no. Usually they are, deformities beauty is in the eye of the beholder, but deformity, meaning they're going to be longer, they may be wider, so that can be perceived as a deformity, but they all tend to create that kind of deformity over time.
Okay, and we're talking about limbs and digits. Do people with Marfan more than the general population have extreme dryness and cuts on skin on fingers and toes, or is that just normal?
I don't know of any correlation. I would just encourage moisturizer, particularly after a shower, because that's a great time for the pores to be open for the moisturizer to get in. But I don't know of any study that highlights that correlation.
Okay, thank you. And here's another a foot question, Dr. Bitterman. A 4-year-old with Marfan syndrome has pretty severe pronation. One advice, less is more, and one is to use orthotics. What do you think?
So the question that I have in return is whether or not it's painful. Certainly it's concerning from a cosmetic standpoint, in particular to a parent or guardian, but generally less would be more to start. If and when it becomes painful, certainly there are means of correcting that with various types of custom orthoses. And my go-to would be a UCBL, which is a University of California at Berkeley laboratory where it was developed. And it's essentially an orthotic that has control of the heel. And those can be very successful from my standpoint to better correct and improve the appearance and improve pain, more importantly.
Great. Okay, thank you. For both of you, what you talked about today, does it apply generally to people with Ehlers-Danlos syndrome? And I think we should think about maybe the hypermobile type, because I guess those are the people with more of those bone and joint issues.
Yeah, that's a great lead in. People with Ehlers-Danlos syndrome have a different defect in their genetics. It's more collagen. It doesn't have quite the same effects on TGF-beta either. They tend to have even more loose ligaments, loose muscle tissue than Marfan patients. They tend not to have as much scoliosis, although they can. And their pain is often more debilitating even than Marfan patients. They often get tired out very easily, have trouble doing tasks that people think they should be able to do. And it's a very mysterious, in a way, syndrome. It's also hard to diagnose because there is no foolproof test for it. So this is something that a condition that's often dealt with by a whole team of people, including a geneticist, an orthopedic surgeon, a physiatrist, in other words, rehab doctor, and physical therapist, and orthotist. So it's quite a bit similar, but also much different than Marfan syndrome.
Okay, thank you. I'm glad we got to talk about Ehlers-Danlos a bit here specifically. What about exercises for Marfan patients? You know, things to strengthen the, the spine, hip, or foot exercises for people with Marfan.
Those exercises should be low isometric. In other words, they shouldn't be generating a lot of internal strain in the heart and aorta. They should be non-impact, but they can be cardiovascular. In other words, getting your heart rate up a little bit and exercising your muscles and the good chemical benefits from that, keeping your bones healthy. Ideal ones might include swimming, walking, sometimes bicycling, but really anything that you enjoy that's not impactful. We're not really in favor of football or high contact activities, but in each case you have to consider what the issues are, whether it be eyes or aorta or heart valves or other joints, and then can come up with some common sense recommendations. And then, of course, the person can choose to ignore or obey those.
Yep, everybody has their choice, but talk to your doctor. Dr. Bitterman, what about bunion surgery in people with Marfan syndrome? Are the outcomes similar to the regular population, or are they worse outcomes?
They're different. Bunion surgery in general is a very difficult pathology to treat because there's a very high recurrence rate. And when you're adding in pathology that involves poor protoplasm from a tendon standpoint or a ligament standpoint, you're at an elevated risk of recurrence as well. So depending on the degree of the deformity, you may wish to have it treated in a different way such that the chance of recurrence is low, and that can be with a fusion as long as that heals. But otherwise, if you're doing certain procedures where capsules are being stretched or tightened, it's important to understand that sometimes augmentation may be needed.
Great, thank you. I think each of you should answer this question. What's the one thing that you would tell your Marfan and connective tissue disorder patients to help with their chronic pain? I'd love to hear what each of you think of that. Dr. Sponseller, you want to start?
Be positive, because many times this goes in cycles, and chronic pain that is currently an issue may eventually kind of go away, either for a good reason or just mysteriously. So try to keep positive, try to keep active, both psychologically and physically as much as possible. Obviously, mobility challenges are part of Marfan syndrome, but still trying to get out by whatever means and be out in the world, socialize, form contact, that can help. And look to all kinds of people to help you. Chronic pain also brings along with it depression, and depression can make it much worse. So try to seek help from a mental health provider whenever necessary to approach it from that angle. Good
points. Dr. Bitterman, you have anything to add to that?
Not really. I think camaraderie with those who are supportive around you is very important. Friends, colleagues, peers with and without the syndrome can be very helpful. And trying to have a positive outlook, because we've come a long way with our understanding of the syndrome, and certainly, as cliche as it sounds, it's true. the sky is the limit. I think you have some very intelligent people that are at the forefront of this, trying to come up with better solutions. So I think the outlook is pretty bright.
I mean, I think I want to add one thing to this. I've heard a lot of pain presentations as part of our conferences and symposiums. And the one thing that really struck me is not to think about getting your pain to zero, but think about your functionality and what is the pain preventing you from doing? So how can you reduce the pain to increase what you want to be doing every day? And so your goal might be a little different. It might not be that you can get to zero on the pain scale, but you may be able to find ways to cope so that you can do what it is that you want to do. And kind of makes you look at it a little bit differently, in addition to all the things that the two doctors here
right, travel more, be with your family, work or whatever it is as a goal. That's
exactly.
Fun.
Exactly. Are there exercises for early juvenile bunions, Dr. Bitterman? She has semi-custom orthotics. So what else would you do to combine with that?
Really no particular exercises to prevent a bunion, but ultimately it's structural. So putting a toe spacer in between the big toe and the small and the lesser toes, that can help. There are commercially available braces that you can wear during the day, at night, but ultimately shoe wear is key. You don't want to wear a shoe that constricts the toes from right to left or left to right. You want to let the toes be free in the toe box. So that's why the brands mentioned earlier, New Balance, Saucony, Brooks, Asics, etc., are very important, because it just lets the toes be there as opposed to pushing the toes over.
Okay, great. We're going to do one more question, but I do want to let everybody know that whatever questions are not answered tonight, I'm going to work with the nurse in our health center to get you guys the answers. So if Dr. Bitterman, if you can answer this one quickly, any opinion on the usefulness of physical therapy for a young child with Marfan to gain strength, balance, and coordination?
Yeah, very important. Core strength is huge, because appropriate posture is vital to preventing worsening issues down the line. So I support it.
Okay, great. So I want to thank Dr. Bitterman and Dr. Sponseller for their time tonight. As I said, we're going to get the rest of your questions answered. Give us a little bit of time, but we will get back to you. We're also going to be sending out a link to the recording. But you know that you can always contact Jen Lynch, who is our nurse on staff. And there's an Ask a Question page on our website, and her phone number is there as well. Our next webinar is March 18th, and that's a presentation on vascular Ehlers-Danlos. And you can register on our website. You see, if you go to the Patients and Families, on the side, you see Virtual Medical Symposium Series. On that page will be the upcoming webinars, and then there'll also be links to previous webinars in case you missed them. Right below that is the Empowerment Series, and those are more quality of life issues, some of the things that Dr. Bitterman talked about, and some solutions, and those people have found very helpful as well. So thank you so much. We do have a survey that we're doing now to get more input from all of you on what topics you'd like to have covered in the future. So we'll send that link out along with some other links that we've talked about tonight on this webinar. So thank you all for participating, and I hope to see you again, or see you again on another webinar in the future. And thank you to the two doctors for participating.
Eileen, thank you for leading such a great interaction.
Yes, thank you.
All right, thank you so much. Have a good night, everybody.
Bye.